Hello, everyone, and just a reminder this is the recorded lecture for class on the second half of Chapter 5 because we will not be having in-person class on Thursday, September 25th because I'm out of town. Just a couple of reminders before we jump into the content. Make sure that you are completing that Chapter 5 quiz on Canvas before the end of the day on Friday, the 26th. After the 26th, the quiz will no longer be available. It is your standard format quiz with 5 questions. The only difference being that this is open note and open book. You just have a timer and you can only take the quiz once. So whatever grade you get on the quiz is the grade that will be submitted. The plan for this lecture is to go over the remaining diagnoses from Chapter 5, which will include specific phobias, social anxiety disorder, post-traumatic stress disorder, obsessive-compulsive disorder, and then related OCD disorders, which will include trichotillomania, excoriation, and body dysmorphic disorder. So to start out our conversation now, I want to talk with you a little bit about specific phobias and just get an overview of what they're about. So specific phobias, the essential feature of these diagnoses is an extreme irrational fear of a specific object or situation. With a specific phobia, it's really important to pay attention to the idea that this is an irrational fear. Most often, specific phobias start with a very rational fear, a fear of a dangerous animal or a dangerous activity that could cause harm. But we get into the phobic levels when that fear becomes all-encompassing to someone's life, or when it is so irrational where it's like every single time that I step outside, I'm going to see a snake, as opposed to when I'm on a hike in a rocky area, I'm likely to see a snake. We're in that disordered level when the fear is no longer justified by the situation. Also, when it comes to phobias, it's important to keep in mind that persons will go to great lengths to avoid phobic objects most often, meaning that they will engage in those avoidance or those escapist tendencies in order to prevent themselves from being exposed to the object or the situation that they're scared of. Most individuals who have a specific phobia diagnosis recognize that their fear and avoidance are unreasonable, yet they're still unable to alter that behavior on its own, which is again where we get into that disorder range. Because if they were able to recognize the fear and avoidance as unreasonable and then alter the behavior, it's no longer causing distress and dysfunction in their life. But because individuals who meet the threshold for a specific phobia diagnosis are unable to make those changes, that's where we get into that disordered level where it's causing distress, it's causing dysfunction in someone's life. There's also a markedly interference in one's ability to function, as well as the parameter of these fears, this irrational fear lasting at least 6 months or longer. This is to take into account that when we are exposed to something for a certain amount of time, individuals are expected to be fearful of it. Once it extends beyond 6 months, that's when we're looking at potential phobic level fears. For phobias, there are some common specific phobias and subtypes that are the most prevalent in diagnosing. It's important to note, though, that people can, in theory, develop a specific phobia of just about anything. There are numerous sites that you can find on the internet with lists of these quote-unquote obscure phobias, and many of them have a neologism or are formed by putting phobia on the end of a classic root word, when in practice, in terms of diagnosis, we oftentimes just rely on the clinical phobias that fall into certain common categories. One of which is the fear of certain situations or certain natural environments, which the picture is a little bit hard to see, but it's that picture in the bottom left. That's a picture from the Skyview ledge in Chicago, and that is to indicate a fear of heights. And natural environment fears are things like a fear of heights, storms, water. Oftentimes, fears of natural environments cluster together, where someone has a fear of one, they may have a fear of another. And they are oftentimes associated with a real danger. So a fear of a tornado or a fear of heights or falling from a great height. the natural environment ones tend to be rooted in real fears. There's also the fear of blood injection injury, which is for individuals who are fearful of blood draws, getting injections, seeing blood from a minor cut, watching others have their blood drawn, or getting injections. Oftentimes, when we hear about blood injection injury phobias, these are the individuals who are touted as like fainting when they see these things. It's a pretty common reaction for this phobia. Another phobic reaction is the fear of animals. That's another common category. Often, animals that are included are things like bees, dogs, snakes, mice, insects. And again, similar to the natural environment, these fears tend to be rooted in real dangers or associated with real dangers. Sometimes for some folks, there is a history of an event or something that happened with one of these animals that encourages the disorder, or at least starts it. It's the diathesis or the stress, but it is then perpetuated or maintained over time. And the final primary category is a situational phobia. Oftentimes these are flying and driving phobias. And with these particular phobias, the situational phobias, there are no uncued panic attacks that occur. The fear is based on the risk of a situation, such as a plane crashing or being in a car and having a panic attack, or the car crashing. So every time that the person is having a panic attack, they are fearful of the situation that's going to occur and not the fear of having a panic attack in that case. Couple of statistics about specific phobias. About 12.5% of individuals in their lifetime will be diagnosed with a specific phobia, with about 8.7% in any given year. This is one of the most common psychological disorders in the United States and around the world. So not just within the category of anxiety disorders, but across the entire DSM, specific phobias are one of the most common psychological disorders. Females outrate males about 4-1 on specific phobia diagnoses, with a lot of theories around why that could possibly be the case. One of which being that, according to research, it's easier for individuals who have been assigned female at birth to describe their fears and be outright with them, which in reality, for a lot of those studies, they're talking about individuals who identify as women, but also happen to be assigned female at birth. So there's a little bit of unknown information given the lack of diversity in these studies. Specific phobias do typically run a pretty chronic course. Once someone meets the threshold for a specific phobia, they tend to continue that phobia rather than having it sort of go into remission. It pretty well stays constant. Onset for specific phobia is oftentimes in childhood. And when we're talking about childhood, I mean like younger childhood, around the time that a child has awareness of fears. So you're looking at right around like 8 years old through 13, 14, 15 is typical onset for a specific phobia. But of course that varies from person to person. Some of the associated features with specific phobias are the primary causes. For some folks, they have direct experience with whatever they are fearful of. So this could be an injury to an animal, or incurring an injury from a height or a natural disaster, their family home being hit by a storm and causing devastation to their community. It could be that direct experience, but it doesn't have to be directly causing the phobia. Individuals can also develop a specific phobia through vicarious experience, which is where they see someone else encounter a feared object. So this can be physically seeing the feared object, but it can also be seeing recurrent videos of seeing a feared object or a feared situation. This is particularly common when we hear about tragedies, especially like plane crashes. A lot of people have these vicarious experiences of seeing or hearing about plane crashes, and then that causing these phobic level fears of that situation or that occurrence or that crash happening. So it's important to recognize that there are multiple sources, because even in addition to these direct and vicarious experiences, we can also hear about it through information transmission. So this can be just learning about a situation or an object and the thought of it being dangerous. Think about, in this case, if you have a family member who's fearful of something and you pass that information on to the next generation. So I've been pretty upfront with all of you that I have a pretty intense fear of snakes. And this is something that has been transmitted across generations in my family. My mother, my maternal grandmother, and all of my maternal grandmother's siblings are absolutely fearful of snakes. And that information has just been passed on, of reiterating snakes are dangerous, snakes are going to hurt you, and that has stuck with future generations, myself included. There's also this component of phobias that we called preparedness, which is the idea that it's easier for us to acquire phobias of things that would have been useful for our ancestors to fear. So for example, we may be more likely to fear spiders and snakes than we are buses, even though buses are more dangerous than spiders and snakes by number. In other words, when we talk about preparedness, through natural selection, we have been prepared to fear certain things more than others, leading to a more likely opportunity for a fear or a phobia to set in. When we talk about treatments for specific phobias, psychological treatments are one of the touted treatments. Primarily CBT, cognitive behavioral therapy, is highly effective, with the specific component of exposure being critical. So essentially, with specific phobias, individuals create a hierarchy of fears, and it is this gradual, structured, systematic progress through reaching their feared situation or their feared object. So essentially, you have the individual create a hierarchy of fear with whatever their top phobia is at the very top of that hierarchy. And then there are smaller steps leading up to it. So if it were me with snakes, my hierarchy might start with, like, the starting step is just hearing people talk about snakes and being okay hearing them talk about it without having panic. Then it might be looking at pictures of snakes. And then the next step up from that might be seeing a video of a snake. And then up from there, being in the same room as a snake but farther away, and then gradually getting closer until at the very end I'm able to touch or hold the snake, being like the top level of that hierarchy. It's a very gradual process. It's extremely structured. The individual with the specific phobia sets the hierarchy up and determines where they want each step to take place. And the role of the clinician in that case is to help the individual decrease their anxiety as they move up the hierarchy. So teaching them relaxation skills, breathing treatments, or it can be just helping through cognitive restructuring in CBT. All of that is going to be an option if we're looking at a CBT exposure approach for specific disorder or for specific phobias. So I have this picture. This is from our textbook, and I think this is really important to highlight how phobias can develop, because there are so many pieces that come into play. Oftentimes, as you'll see in the far left in that orange box, you'll see my cursor over it here. Oftentimes there's a stress due to a life event that is going to activate false alarms, but that false alarm leading to a specific phobia really comes from an original place of actual fear. There's a direct experience or direct exposure or vicarious exposure to this feared object, which may lead to a true alarm. So an actual fear that is justified, and then we have a learned alarm that comes with it, a panic attack in some cases. And it isn't until after that happens that the stress of life creates a false alarm that we can then bypass that true alarm into the learned alarm and then eventually into that specific phobia. So there's many steps that come into play that lead someone to developing a specific phobia. When it comes to specific phobias, one celebrity who has been pretty upfront about their phobias is Whoopi Goldberg, who has a specific situational phobia. She has a fear of flying to the extent that she will not get on a plane and will travel by bus when possible. Excuse me. I do have another video here of a real person living with blood injury phobia. Unfortunately, because I'm uploading this lecture to YouTube, I can't show you the video right now. So what I'm going to do is I'm going to create a document that's going to have all those links for the real phobias or the real disorder experiences, and I'll put them on Canvas for you so that you can watch them when you have some time. So the next disorder that we'll talk about is social anxiety disorder. The essential feature of social anxiety disorder is an extreme or irrational concern about being negatively evaluated by others. The key with social phobia is that this is not just being uncomfortable in situations. It is explicitly this fear of being evaluated negatively by other people beyond what would be expected. So, for example, we oftentimes have a fear that when we meet with our teachers or when we are taking an exam that we are being evaluated by other people. Think of when you're going in for an interview for a job. You're going to anticipate being evaluated by others, and you're going to be fearful that you might be evaluated negatively by those individuals. When we get into the social anxiety disorder level, the disordered level of this fear, this is when it is extreme and irrational to the point that the individual is no longer going out into public situations because the fear of evaluation is so great. And again, because of that, they're oftentimes avoiding social situation or engaging in them with great levels of distress because that fear is still present. Sometimes, but not always, social anxiety disorder can come across or manifest as shyness, but this is not true for everyone. There are many individuals who are shy who do not meet the threshold of a social anxiety disorder diagnosis, and there are many individuals who have social anxiety disorder who don't identify as shy once they are opened up to someone and once they are able to overcome that fear of evaluation. There is a particular subtype of social anxiety disorder, and that is what we call performance-only social anxiety disorder. And this subtype tends to be associated with just a fear or anxiety in performance situations, such as public speaking or having to present in front of a class where there is this performance piece. So think about people on a stage or in front of a large group of people having to give a speech. Those are the situations where we would assign a social anxiety disorder performance-only subtype. Performance-only subtype tends to be less interfering just because individuals are able to function in most social situations without a problem. It's just when they get into that performance level that they're starting to have dysfunction. And oftentimes, individuals with the performance subtype, when they're in professional and engagement or educational situations, they're able to adapt their performance. So they might not speak up at meetings, or they might avoid classes that require presentations. So you can see people using adaptive skills to try to avoid the thing that is fearful for them. Social anxiety disorder is also pretty high, similar to specific phobias. Around 12.1% of individuals in their lifetime will be diagnosed with social anxiety disorder, with about 6.8% of people in any given year. This is a pretty clean ratio. We expect the diagnosis to be pretty common in both individuals who are assigned male and those who are assigned female at birth. The onset for social anxiety disorder is pretty young, usually in adolescence, with a peak age onset at 13. So meaning within a range of about 2 years on both ends is when we oftentimes see social anxiety disorder onset starting, but also when it is most likely to be diagnosed. Social anxiety disorder is more common amongst individuals who are aged 18 to 29, who are undereducated, single, and of low socioeconomic status. Whenever we do incidence studies on social anxiety disorder, this is the category of people who come across as being the most at risk or the most common identifiers for social anxiety disorder. Part of that is situational circumstances in people's lives, but also some of that could be a reciprocal relationship where the social anxiety disorder is making it harder for people to go to school, harder to maintain a job because they want to work from home, because they have this fear of negative evaluation, and that being most common amongst young adults because that is when you are starting to establish career, starting to complete your education, and maybe even starting romantic relationships with others. When it comes to social anxiety disorder, the primary treatment that is touted is medications for a lot of folks. They can be diagnosed beta blockers, which are often used by performers such as musicians because they really help to combat stage fright. Benzodiazepines are also another common treatment because they are really good at calming the system down rapidly right before a presentation. SSRIs are more commonly prescribed for general social anxiety because they are a little bit more stable over time, whereas we've talked about already, benzos oftentimes we build up a tolerance to them. We need more and more of it over time. SSRIs are more stable and they don't need to be adjusted quite as frequently. D-cycloserine is an antibiotic that was originally used to treat tuberculosis. It has a component that we call a cognitive enhancer that improves what we call extinction learning, or the learning that occurs when someone is engaged in exposure therapy, where they're learning to be less fearful of the object that is fearful for them. So in other words, they are extinguishing the fear that is irrational in favor of something that is more rational for them. So D-cycloserine has this cognitive enhancer where we're able to enhance extinction learning so that someone can decrease and cope with their feared situations a little bit easier. And some studies have shown improved outcomes for folks that are on this medication for social anxiety. There are also psychological treatments with, as you would suspect, CBT being the most prominent. Particularly in CBT treatment, there is this challenging of anxious thoughts about the consequences of social judgment. So walking through with someone, what's the worst thing that they could say? Okay, how likely is that to happen? What's the best thing that they could say about you? How likely is that to happen? And what's in between the worst likely and the best likely? How likely is that to be? Oftentimes with CBT for social anxiety disorder as well, there is this exposure to anxiety-provoking situations. So going with the individual into their environment and having them practice in the therapy room, maybe giving a speech to just you and then inviting one person in and then giving a speech to 5 people and then increasing to a speech for 8 or 10 people until they're able to give a public speech. There can also be rehearsal components and role plays where there's less stress on it, but still getting the individual comfortable engaging in that social interaction with the possibility of evaluation. CBT is really effective for social anxiety disorder. It just takes more time than medications, which is why oftentimes people might start on medications while they're beginning treatment so that they can eventually titrate off of the medication in favor of the psychological treatments. So our celebrity who has been pretty vocal about their experience with social anxiety disorder is Jennifer Lawrence. And again, I will post the video of the real person living with social anxiety disorder in Canvas for you to watch. So that wraps up our conversations about anxiety disorders. And next we're going to transition to talking about the trauma and stressor related disorders. As a whole, trauma and stressor-related disorders as a category was new to the DSM. So previously in the DSM-4 text revision, trauma and stressor-related disorders were encapsulated with anxiety disorders, but they were separated out in the DSM because there was this sort of overarching theme that a stressful life event could cause a disorder in a way that was different from what was experienced by anxiety disorders, where anxiety disorders oftentimes are more insidious, they come on gradually. With trauma and stressor-related disorders, there's a more acute onset and theme of this stressful life event. So, one of the most common trauma and stressor related disorders is post traumatic stress disorder, but that's really just one of many trauma and stressor related disorders. There's PTSD or post traumatic stress disorder, but there's also acute stress disorder, attachment disorders, and what we call adjustment disorders. For this class, we're only going to talk about PTSD and acute stress disorder, but do keep in mind that these other disorders are there. It's just a little bit beyond the time that we have in our class to talk about these things. So, in terms of post-traumatic stress disorder, the essential requirement for a diagnosis of PTSD is exposure and response to trauma. So in the DSM, a trauma exposure or a traumatic exposure means that an individual has experienced or witnessed an event in which death, serious injury, or sexual violation occurred or was threatened to either that individual or someone else. Or they learned about violent or accidental death or serious injury occurring to a close loved one. Or they have an extreme aversive exposure to details of traumatic events, which can include individuals who maybe are first responders and they are responsible for cleaning up crime scenes or collecting items related to murders or an explosion or some traumatic event. So, as you can see from this definition, traumatic exposure within the DSM is quite narrow. Again, traumatic exposure means witnessing an event in which death, serious injury, or sexual violation occurred or was threatened to the individual or to someone else. They have learned about the violent or accidental death or serious injury occurring to a close loved one, or an extreme aversive exposure to the details of traumatic events, such as those experienced by individuals who have to go clean up at explosions or crime scenes. With individuals who have that traumatic experience, in order to meet the threshold of a PTSD diagnosis, there also has to be this re-experiencing component. They are having negative and distressing memories of the event, nightmares that are waking them up in the middle of the night, flashbacks, so moments where they get lost in the memory or the images of the trauma in present day, and it reverting them back physiologically to that traumatic event. So keep in mind that this re-experiencing component is key for a PTSD diagnosis, as well as an avoidance component. When we talk about avoidance, this is where their individuals are avoiding things that might remind them of their traumatic experience. They are altering their life so they no longer go to places. They avoid people. They might even avoid situations that cause them to feel similar to how they did when they were in their traumatic experience. So if they maybe experienced high levels of stress during the trauma and their heart rate was elevated, they might avoid working out because they don't want their heart rate to be elevated. So avoidance can occur situationally, physiologically, and even psychologically, avoiding thoughts and emotions associated with the trauma, which then leads for many individuals with PTSD to experience emotional numbing and interpersonal problems, where they're like at a point that they don't want to experience any emotions associated with the trauma. It's just easier to stay at a baseline, no highs, no lows, but also in that causing conflict in their relationships with others, difficulty interacting, expressing themselves in a way that feels safe, but also is not giving power to the PTSD or reactivating the PTSD is probably a better way to describe that. So keeping in mind how that applies in their actual day-to-day life. With a PTSD diagnosis, these reactions, the re-experiencing, the avoidance, the emotional numbing, the interpersonal problems must persist for at least 1 month or more following the trauma. If they are experiencing all of these symptoms, but they are below 1 month within the trauma, they are given a diagnosis of acute stress disorder. So acute stress disorder has the exact same criteria as PTSD minus the timeline. The timeline for acute stress disorder is less than 1 month after the trauma occurred, where PTSD is 1 month or longer of these reactions after the trauma has occurred. In terms of statistics for PTSD, about 6.8% of individuals in their lifetime will be diagnosed with PTSD, with anywhere around 3.5 individuals in any given year meeting the threshold for diagnosis. Most individuals who have an exposure to a traumatic event don't go on to develop PTSD, but some people do. We highlighted this a little bit in class on Tuesday, but just the exposure to trauma does not automatically mean that someone will have a PTSD diagnosis. There's a specific subset of people who have been exposed to trauma that then will go on to develop PTSD, and we're really still trying to understand who those individuals are and what mechanisms put them at higher risk. And we really don't know. But what we do know is that individuals who have been exposed to sexual assault or who have been targeted for sexual assault are 2 to 3 times more likely to develop a PTSD diagnosis. And the closer someone is to a traumatic event or traumatic exposure, the more likely they are to develop PTSD. So think about in the experience of an explosion. If there's an explosion in a community, individuals who live right next door to where it happened, or individuals who lost someone to the explosion, are more likely to develop PTSD than individuals who live 3 towns over and didn't know anyone who was involved. So that exposure piece, or that proximity to the trauma, is going to increase the likelihood of a PTSD diagnosis. So what we do know about the causes of PTSD, again, is that the more intense a trauma is and the closer someone is to it, the more likely they are to develop PTSD. But that's not the only thing that puts someone at risk for developing PTSD. There also tends to be a generalized biological vulnerability. Specifically, twin studies have shown that when both twins are exposed to trauma, such as in combat, identical twins have higher concordance rates of PTSD compared to fraternal twins. So what that means is, for fraternal twins, they are less likely to both be diagnosed with trauma, even if they're exposed to the same trauma, whereas identical twins are more likely to both be diagnosed if they are both exposed. We also know that there are certain genes that are associated with a greater likelihood for developing PTSD, and when those genes are activated or are added to by stressful life events, they sometimes make it so that individuals put themselves in situations where they are more likely to see more trauma or more frequently see trauma. So there's this reciprocal gene environment interaction where both the gene and the stressful life events are encouraging one another or amplifying one another. There's also a generalized psychological vulnerability that comes into play, particularly individuals who have beliefs about their life being uncontrollable or unpredictable oftentimes have a greater likelihood of a PTSD diagnosis. But when those beliefs about uncontrollability and unpredictability are specific to threatening situations, that's when PTSD is more likely to occur after someone has been exposed to the traumatic experience. And we also know that poor social supports increases someone's risk for developing PTSD. When they have a greater social network and individuals that they can talk to, the less likely they are to develop PTSD, which is why we oftentimes see a lot of trauma exposure support groups to help prevent the onset of PTSD for folks. For individuals who are diagnosed with PTSD, psychological treatments are the most touted option, and primarily it's a CBT or CBT related treatment. They are the most effective, and oftentimes PTSD for trauma, or not PTSD, CBT for trauma is really heavily focused on imagining exposure to the trauma. So going through someone's memories of the event and walking through what they remember, what they don't remember, what they felt like was in their control, what was outside of their control, and putting that into a realistic expectation for control moving forward in their life. So in one particular type of cognitive behavioral therapy called cognitive processing therapy, it is the most efficacious treatment for PTSD, meaning it is the most supported by research and evidence. It primarily focuses on restructuring cognitive thoughts related to trauma. So going back through and having a realistic expectation of what the individual themselves was responsible for and what the individual who caused the trauma is responsible for. Also, with these CBT treatments, you're going to really work on developing and increasing the utilization of positive coping skills, and that ranges from person to person, but you're also going to focus on increasing that social support, getting the individual involved in trauma groups or just expanding their social network of people, so developing closer friendships. There are medications that can be used for PTSD. Primarily, SSRIs are really helpful. They are fantastic at addressing the anxiety level, the baseline anxiety, and help reduce the risk of experiencing panic attacks for individuals who have been diagnosed with PTSD. And the celebrity who has been pretty upfront about their experience with PTSD is Ariana Grande. And I do have an amazing video about dogs that have been trained to help folks who have been diagnosed with PTSD, and I will post that for you all as well on Canvas. So our final category of diagnoses that I want to talk with you all about is the obsessive compulsive and related disorders. This is a pretty wide topic for the DSM, but overall it's a fairly new classification. Before the DSM-5, obsessive compulsive and related disorders were again under the umbrella of anxiety disorders and anxiety related disorders, but they were separated out because of their theme or this added piece of recurrent thoughts and recurrent behaviors that are causing harm to someone. Within the umbrella for obsessive compulsive and related disorders, we have obsessive compulsive disorder, OCD, hoarding disorder, body dysmorphic disorder, trichotillomania, and excoriation. We're only going to talk about a few of these, so just keep in mind that there are more than what's listed, but I'm just going to cover the ones that I think are the most important for you right now in class. So obsessive compulsive disorder and related disorders have these two primary definitions that are going to be important for you to know about. And those are both obsessions and compulsions. Obsessions refer to the intrusive and nonsensical thoughts, images, urges, and attempts to resist or eliminate those thoughts or images or urges. So think about obsessions as being the internal component of an obsessive compulsive disorder. It's the part that we can't see. It is what's going on in someone's head, the repeated images or thoughts of something or the urge to act in a certain way, but not the outright behavior. Some examples of obsessions for folks might include doubting themselves, like did I lock the door? Did I close the door? It can also be thoughts about contamination or germs, unwanted sexual, aggressive, or religious thoughts, nonsensical thoughts or urges like being undressed in public or thinking about undressing in public. It can be thoughts about accidentally harming someone else, like did I hit someone with my car? Did I run someone over? It can also be a need for symmetry for some folks, so things needing to be exactly even or exactly balanced and equal for people. And these obsessions, again, think of them as being that internal component where the external component is what we call a compulsion. These are the thoughts and actions that someone engages in. For some folks, not everyone, engaging in the thought and action provides them a sense of relief from their obsessive thoughts. Sometimes they are tied to specific obsessions and other times they're not. So for example, if someone has an obsessive thought of contamination or a fear of contamination, they may, but not always, have the compulsion to wash their hands many times every day, all day long to fight that contamination. So when we're talking about washing hands, we're talking about the excessive. So washing hands until they are cracked and bleeding, or spending multiple hours per day washing. Some other compulsions that are pretty common are checking appliances excessively, making sure that they're turned off. It can also be counting, so needing things to occur in a certain number, like always in sets of 3 or in sets of 5, sets of 7. It can also include behavioral rituals, so getting dressed in a very specific ritualized way or pattern. There can also be mental compulsions where we might repeat a prayer in our mind over and over in response to an unwanted sexual thought, or an internal thought punishing of like saying something harmful to yourself, like you're dirty, you're gross because you thought of this. So those compulsions most often are physical and observable, but they are sometimes internal. There are 4 main categories of compulsions, and those are checking, so making sure that a door is locked or a light is off, an appliance is turned off. Ordering or arranging, so making sure that things occur in a specific order and then arranging things to be that way. And so those are 2 separate categories, ordering and arranging. And then the final primary category of compulsions are washing or cleansing. As a whole, for OCD, the essential feature for obsessive compulsive disorder is the presence of an obsession, compulsion, or both. So a lot of times people hear the name obsessive compulsive disorder and think that it has to have both obsessions and compulsions, but you are able to get a diagnostic label for OCD with just the obsessions and just the compulsions. The key piece for an OCD diagnosis, though, is that whichever or both they have, obsessions, compulsions, or both, they must be time consuming. They must take up multiple hours of someone's day. They're spending 4, 5, 6 hours counting things, checking things, washing their hands, to the point that it is interfering with their ability to complete other tasks in their life. They're not going to class. They're not completing their tasks at work. It's interfering with their relationships. And for many folks who have been diagnosed with OCD, it causes a great deal of distress. They know that this is not something that they want to be engaging in, but there is this desire to continue doing it because of the fear underneath that something bad might happen if they don't. For some folks, that's not true for everyone, but for some folks who've been diagnosed with OCD, it's really hard to break that cognition that I have to engage in this checking behavior, this counting, this hand washing, because if I don't, I'm going to get sick. Someone in my family is going to get hurt. I'm going to get hurt. And it can be really difficult for folks to recognize that that is not functional in their life, but also not feel like they have the ability to stop. For OCD, it's a relatively lower incidence rate. Between 1.6 and 2.3% of individuals in their lifetime will get diagnosed with OCD, and about 1% of individuals in any given year have an OCD diagnosis. We see a common distribution amongst individuals who are assigned female and those assigned male at birth. The onset for OCD tends to be between childhood and age 30. So for some folks, they're able to engage in these behaviors a little bit more under everyone's radar, which is typically where we see individuals not developing their symptoms and being diagnosed until they're in their 30s. But sometimes we see it being very acute onset, very obvious, very disruptive to someone's life as early as their childhood. OCD does tend to be chronic. For folks who have been diagnosed, there are some who go through their entire life and their symptoms are relatively stable. There are some folks who will go through waves of obsessive compulsive disorder activation. So points in their life where their obsessions, compulsions, or both are more active, and then parts where they are not, where they're in like a quote unquote remission state. It just sort of depends on the person. OCD as a whole, we see it being tied heavily to early life experiences. So, messages that someone receives about specific thoughts or behaviors being appropriate or inappropriate can sometimes encourage the development of OCD for folks. So, think about messages that we receive around hand washing and that it's necessary and that we have to do that, otherwise we're going to get sick and we're going to die. If it's to that extent, if it's that serious, those early life experiences, hearing those messages can make it easier for individuals to develop OCD. We also learn associated with this that some thoughts are dangerous and unacceptable. Think about yourself in context here about some of the things that you may have heard from your parents, your teachers around sexual behavior or what's considered dirty behavior or dirty thoughts, and how exposure to those things may have influenced your beliefs about engaging in those thoughts now as an adult. So, for a lot of folks, when we talk about these early life experiences and these thoughts, we oftentimes also talk about what's called thought action fusion being a factor with OCD. So, thought action fusion is where individuals equate having a thought with a specific outcome or action that's associated with that thought. So, for example, if I imagine my spouse dying, it means he's going to die. That's thought action fusion. The thought is associated with the action actually happening, even though it's probably not likely in that circumstance. But for individuals who have an OCD diagnosis and are experiencing this thought action fusion, the thought is similar to the action in the sense that thinking something will happen will make it more likely to happen. And because of that, for them, the thought is fused with, if I have the thought, it means that the behavior is going to happen. So I can't have the thought. I need to get rid of that thought. I need to avoid it. I need to distress. I need it to not happen in my life. Treatment for OCD. Biologically, there are some medications that can be useful, particularly SSRIs benefit about 60% of individuals. They're a good maintenance treatment for getting someone's symptoms to a more manageable level, but there is a high relapse rate for folks who take SSRIs when they stop taking the medication, causing them to experience a recurrence or resurgence of their symptoms. For some folks who don't respond to medications but want to try biological treatments, there are some psychosurgeries that are options, particularly sigulometry. I always pronounce it wrong, so I have to say it slow. Sigulometry, which is used in very extreme cases of OCD where the connection between the frontal lobe and the limbic system is destroyed or cut away. So they sever the connections between the frontal lobe and the limbic system to make it so that the emotions and thoughts that someone are experiencing are separated. Because remember, the limbic system is responsible for our animal drives and our emotions, and the frontal lobe being heavily involved in our thought processes. So if we're able to sever that connection, we can create a little bit more distance between thoughts and emotions so that they aren't as intrinsically tied. But psychosurgery for OCD is only used in extreme cases where other biological treatments don't work, but also psychological treatments are not working. Psychological treatments for OCD are cognitive behavioral therapy based. There are specific subtypes of CBT, one of which being exposure and ritual prevention, or ERP, which is a specific type of CBT that is used for OCD. And ERP works by exposing an individual to cues that would trigger an obsession and then engaging in prevention of compensatory compulsions. So triggering the obsession, but preventing them from engaging in any physical thoughts or behaviors that would try to mitigate those thoughts. So, for example, you might have an individual who has a fear of contamination who washes their hands compulsively and has to touch every doorknob in their house and then make dinner without washing their hands. So make sure that you're activating that thought of contamination by touching all those doorknobs, and then go make dinner without washing your hands to really prevent the compensatory behavior of washing, while also restructuring the cognition that it's okay if I have some dirt on my hands and I'm not going to get sick from it. So really like showing evidence that someone doesn't always get sick. So, in terms of celebrities who have been diagnosed with OCD, one of those is Howie Mandel. Might be a little bit ahead of your generation, but he used to host a game show, Deal or No Deal, and he was known because he would never shake hands or hug any of the contestants. He would only give fist bumps because he had this tremendous fear and obsession of contamination, and then engaged in lots and lots of compensatory behaviors. For him, it was a lot of hand sanitizer, especially when he was working on set, because he didn't always have access to a sink to wash his hands. But a less known individual or celebrity who's been diagnosed with OCD was Howard Hughes. Howard Hughes was a prominent American producer for films like The Racket, Hell's Angels, Scarface, The Outlaw. He was also an aerospace engineer. He created a lot of aircrafts of his own and then sold his designs to other agencies and facilities to use for their larger builds. Howard Hughes was known for his overwhelming OCD that got much more advanced as he got older. So his symptoms, his obsessions, and his compulsions became much more intense as he got older. Towards the end of his life, he would burn any clothes that he was wearing if anyone near him was sick. He started to isolate himself from other people. He would spend weeks on end in hotel rooms, that he would close all of the windows and lock all of the doors because he had this thought that the sun would cause him to get sick. The sunlight itself would cause him to get sick. So he would close all of the curtains in his hotel rooms, tape them shut, and lay in the hotel room completely naked so that he wouldn't get sick. And Howard Hughes is really interesting because in reflecting on his OCD diagnosis, he realized that he received a lot of his contamination obsessions from his mother, who had this constant worry about Howard being exposed to germs because she was fearful that he would develop polio. Because at the time, polio was rampant across the United States and we knew very little about how to prevent it. So she became fearful that something would happen to her children if she didn't protect them. And her way of protecting them was to wash their hands, make them shower all the time. And that fear for Howard really just amplified as he got older. In fact, he insisted on using tissues to pick up objects to insulate himself from germs as he got older in his life. Another diagnosis related to OCD is what we call hoarding disorder. Hoarding disorder was previously considered a subtype of obsessive compulsive disorder, but in the DSM-5, it was separated out so that an individual can be diagnosed with both OCD and hoarding disorder, or exclusively one or the other. And the essential feature of hoarding disorder is the excessive collecting or keeping of items regardless of their value, or and having extreme difficulty discarding of those items because there is this unusual fear that one will need that item in the future. And the collection, the excessive collecting or keeping of items, starts to expand to the point that it creates extreme clutter and disruption of one's living space, where there's only narrow pathways that someone can walk through in their house. There are items of food that are old and maybe rotting in someone's home, but they can't get rid of it. There's this tremendous distress related to getting rid of it that prevents them from actually being able to throw those items away, again, because of that intense fear that they might need that item later in their life. Symptoms of hoarding disorder typically get worse with each passing decade. So when someone has a hoarding disorder diagnosis, their symptoms oftentimes start to intensify. to the point that they also start to engage in a lot of isolation. They're staying home, they're not letting others into their home, which then makes their symptoms intensify even further, because if there are no other individuals in their life helping them throw things away or getting rid of things or helping keep their collecting tendencies sort of at a minimum, the clutter and the disruption gets larger and larger, and the fear of throwing something away gets more intense as they get older. There are also some associated obsessive compulsive disorders called trichotillomania and excoriation. Trichotillomania is the diagnosis given to someone who has this urge to pull out their own body hair from anywhere on their body. And the hair pulling gets to the point and is engaged in so often that it results in noticeable hair loss. So oftentimes for folks, the areas that are primarily affected are the scalp, pulling out hair on the scalp, eyebrows. For some people, it's their eyelashes, but it can also include their arms, their legs, pubic regions, pulling out the hair until it is noticeably missing. And it is this urge, this obsession, or this thought that I need to pull that hair out for whatever reason. And trichotillomania is different from excoriation, where trichotillomania focuses on hair. Excoriation is the repetitive and compulsive picking of the skin. So picking at skin until it leads to tissue damage. So scabs are not healing, skin is frequently bleeding or broken open, scars are developing to that extent is what we're talking about with an excoriation diagnosis. The face is a primary target for excoriation, but other parts of the body, such as the legs, arms, chest, can also play a factor. It just tends to be more common in the face. For some folks, this comes across as this idea that they have a blemish on their face that they must pick at, and they continue picking at it so that it never stops bleeding. It's constantly being reopened, leading to scars. The behavioral habit of picking and the urge to pick is the primary target for treatment for excoriation and trichotillomania. So oftentimes you're looking at a behavioral-based therapy, so behavioral therapy specifically, as being the most effective treatment because you're working on changing the behavior or reversing the behavior. I'm going to show you a couple of pictures of both excoriation and trichotillomania here in a second. So just a heads up that some of these images might be a little bit graphic, but the two images on the left are images of folks who have had and been diagnosed with trichotillomania. The top image being the eyebrows being picked out and the bottom image being the hair on the scalp. And then the two images on the right are pictures of excoriation, particularly with these individuals, the picking at the arms, chest, and legs. So you see that it's continually picking. So these wounds are not healing, they're scarring, and then the scars may become a source of picking as well. And then the final obsessive compulsive disorder that I want you all to know about is what's called body dysmorphic disorder, which is the essential feature of BDD is a preoccupation with some imagined defect in appearance. And within this essential feature, you'll see that it says an imagined defect. For folks, there may be some defect that others notice as well, but for someone to meet the threshold of a body dysmorphic disorder diagnosis, the preoccupation has to be all-consuming in their life. And if there is a real defect, it needs to be slight to others if it is there. So for some folks, it might be this thought that they are overweight and that their body is ugly because they have an extra dispersion of fat around their midsection. Where other people might say like, no, you weigh 100 pounds, you're 5'4", you weigh 100 pounds, and yeah, you have a little bit of fat, but like we would expect that on your body because of your assigned sex or because of this activity that you engage in. So it might be a very slight defect to others, but for that person, it's amplified. It is this intense preoccupation with this defect. BDD is comorbid with OCD in about 10% of cases. So what that means is about 10% of folks who have an OCD diagnosis also have a body dysmorphic disorder diagnosis. But there are folks who have BDD who do not also get diagnosed with OCD. BDD tends to be lifelong for folks. It has an insidious onset, so it is a gradual onset that develops over time, but once it is there, folks oftentimes are experiencing the thoughts and the behaviors associated with BDD throughout their life. There is a little bit of a connection to BDD diagnoses and plastic surgery. In fact, one research study found that let me backtrack. About 8 to 25% of individuals who request plastic surgery may have a body dysmorphic diagnosis. And interestingly, with this connection, plastic surgery does not make the body dysmorphic disorder diagnosis go away. In fact, engaging in the plastic surgery often intensifies the symptoms of BDD, or they may shift to a different part of the body. So it's just important to keep in mind that there may be this connection to plastic surgery, where we're looking at up to a quarter of folks who are requesting plastic surgery may meet the threshold for BDD. When we reverse that and we look at just the folks who have been diagnosed with body dysmorphic disorder, up to 75, just over 75% of folks who have that diagnosis seek plastic surgery as a treatment. And 66% of those folks are already receiving plastic surgery as treatment, which is really concerning to think about. When we hear that BDD doesn't go away with plastic surgery, it oftentimes becomes more intense following plastic surgery. So our celebrity who hasn't been diagnosed with BDD but was actually diagnosed with trichotillomania is Olivia Munn. She particularly will pull out the hair on her scalp, her eyelashes, and her eyebrows. And then I'll have that video for you of someone living with BDD and what their experience is like. I will give you the heads up on the BDD video. It is quite old. It's almost 20 years old. So there are some languages, there's some language that's used that's not appropriate in our understanding of accessibility as well as just inclusivity in our day and age now. And what I want you to focus on is the individual symptoms and their experience of living with BDD. So that wraps up our lecture for the rest of chapter 5. Make sure that you're completing that chapter 5 quiz on Canvas before Friday and reading chapter 6 before class on Tuesday next week. And I will plan to see you then. Have a great homecoming weekend, and I'll see you all in class again on Tuesday.